Welcome, everybody. Again, my name is Louis Shendowich. I'm a PGY5 Hematology and Oncology Fellow. Today, we're going to be talking about two specific models, Tempus as well as CARIS. They each have their own AI tissue of origin models. We're going to be comparing and contrasting them today and seeing what advantages each model has. So let's start with the clinical problem. It begins with cancer of unknown primary, and that appears to be present about 2 to 4% of all cancer patients that present with no specific primary site. Cancer of unknown primary is a metastatic malignancy in which a comprehensive evaluation fails to identify any specific cancer site. The standard workup is pretty comprehensive. You have a histologic review, and oftentimes that results in an insufficient or it potentially is a poorly differentiated tumor. IHC often narrows the category, but does not specify which site of origin the tumor has. Tumor markers also can assist in the diagnosis, but they're usually not actually diagnostic. So some common IHC dilemmas is if you have CK7 positive, CK20 negative. This can be a specifically versus of lung versus upper GI versus pancreatic biliary cancer, as well as TTF1 positive, which can be extrapulmonary or actually lung-specific adenocarcinoma. On the right here, this is actually the New England Journal of Medicine and how they split up the specific IHC markers and tumor markers on pathology. So let's jump right into the two separate models. We're going to start with the more simple model, which is Tempus TO. So what is it and what is it supposed to do? The goal of this is to really find the tissue of origin specifically. It's meant to predict the most likely tissue of origin. And how does it do it? It's a machine learning model based on RNA expression profiles of thousands of tumors. It's designed primarily for cancer of unknown primary, but it's also made for ambiguous cases. There's no specific extra tissue that is required for these type of testing. And the input is just RNA expression. That's the only thing that it's run on. The output is a probability across 68 tumor subtypes, and it gives you the top subtype. It's predictive tissue of origin. On the right, you can see an example of Tempus TO and what it might present as. There's different models of this, so this may not have been the most up-to-date picture, but this is on their current website. They report that, for instance, in this specific case, that pancreatic adenocarcinoma is about 75% probability, and that's the #1 predicted diagnosis. So that is a sample report of what you might see on it. Now, it doesn't always give you an actual cancer. It can report indeterminate if the confidence is low, and we're going to talk about that in 1 minute. So now we're going to actually talk about how the model was made. Specifically, what was the data that the model was trained on? Tempus TO was trained on about 43,700 samples with known primary. It includes 68 histologic tumor subtypes, including primary and metastatic samples, and cancer of unknown primary were actually excluded from the training. How the cases were actually selected, and specifically the quality control, an internal pathologist looked at the specific cases and removed anything that might be ambiguous. These are high quality cases with known diagnoses of known labels. RNA quality as well as tumor purity was required for them to be a candidate to actually be a part of this specific training cohort. And the Tempus prioritized clean, high confidence labels over dataset size to maximize trust and interpretability. The trade-off is that it's not as large as the CARIS dataset that we'll talk about that they used for training, and there are really fewer real-world edge cases. So, where it's not quite clear where the actual diagnosis is, that was not included in the training dataset, which can be an advantage or a disadvantage. The key takeaway from this is that the model was trained on high-quality samples with known diagnosis and not cancer of unknown primary. On the right, you can see the specific breakdown of the actual cancers that were used, the RNA sequencing, the labeled samples, and the training data. They separated it into training data as well as validation data. So the validation data was not used for their training. They separated it. We'll talk about that next. So in regards to how the model was made, we're going to briefly go over the architecture. And in regards to the specific model architecture, they used a multinomial logistical regression. This is a machine learning model. The model begins with random weights assigned to each RNA feature. It is trained on many tumors with known diagnosis for each case, and it makes a prediction. It measures how incorrect it was, and then it updates the weights accordingly based on those RNA features. It acts like a scoring system. Each RNA signal adds or subtracts weight. All the weights are then added together to give a final score, which is really converted into a probability. The highest probability is the predicted cancer. And if the highest predicted probability is above 35%, then a tissue of origin is reported. If the highest probability is less than 35%, then the result is reported as indeterminate, which means that it has a low confidence that this is actually the diagnosis. There were specific features to this model, such as upweighting of rare cancers, meaning that there was a population of very rare cancers and they gave extra weight to those specific tumor types so that the model can really understand or recognize the important cases during training. The model must separate cancers using simple additive rules. It's no complex hidden layers here that we'll kind of talk about a little bit later in the CARIS AI. The clinical translation is that the model can only make decisions it can explain linearly. Similar to how TTF1 positive IHC supports lung cancer, you can kind of think of it in the same process in regards to this. You have a direct probability of having a specific cancer type based on that RNA feature itself. The validation strategy, remember, they're separated into training and validation. It was validated in a couple of different steps. First, the technical validation, specifically the labeled tumors. It was trained and tested on tumors with known primaries, like we talked about, is 68 histologic subtypes. The mean accuracy was around 91% balanced across common and rare tumors. You can see on the right, on figure 3, the specifically most difficult to diagnose tumors, including small bowel adenocarcinoma, metastatic breast, as well as goblet cell adenocarcinoma, and even neuroendocrine lung tumors. You can see that the ranked probability 1, 2, and 3, meaning the 3 cancer types that they may provide, have different sensitivity levels. So for instance, the first rank, it's not always as sensitive as you may want. The sensitivity sometimes is even below 0.5, whereas the cumulative of the 1, 2, and 3, you can see that it can correctly predict the rare tumors in the top 2 or 3 predictions. It's not perfect, and this model should not be taken by itself as a base truth. So for generalizability, they also evaluated this model, Tempus TO, on external data sets, specifically the Cancer Genome Atlas, and it had about an 83% accuracy when it was run on tumors provided by them. This is going to be important because the CARIS AI also runs on TCGA, which we'll talk about in a minute as well. So not only did they do a technical validation, but they also did something biologic as well. They used DNA mutations that the actual tumor model did not see. So remember, Tempus TO only uses RNA. However, they compared it to DNA mutations to see if there's some biological truth to the predictions. So it predicted subtypes that would show expected mutation patterns. For instance, KRAS is very likely in pancreatic, APC for colorectal. And even though the model never saw the DNA, its RNA-based prediction aligned with the expected mutation pattern in around 95% of the cases, supporting biological validity. Now they actually did present some real-world data to see how physicians in the real world are using this. And what they did is that they ran Tempus TO and used data from healthcare claims. So the population was specifically from pathologist-confirmed cancer of unknown primary. So this is specifically the cancer of unknown primary patients. They looked at continuous claims pre and post testing. They found that after the test had been ordered, around 60% of cancer of unknown primary patients had a subtype aligned diagnosis or treatment after the testing. The limitations were that this is not a randomized prospective trial. This is all just insurance claimed. There's no direct survival or treatment response outcomes that have been reported. I don't think they're going to be able to get it either from just the healthcare claims alone. It'd be something very difficult to randomize. And on the right, you can see some of the specific diagnoses that are impacted. One of the more common ones was lung adenocarcinoma. And again, these are specific cancers that were given the diagnosis after Tempus TO had provided them with those results. Originally a cancer of unknown primary, then transitioned over to a known diagnosis. Interestingly, though, the medications did also change. And you can imagine that giving combination immunotherapy may be very difficult in certain cancers, specifically cancer of unknown primary, when you might want to give it more frequently in lung adenocarcinoma or other cancers that may respond better to immunotherapy. Some of the strengths and limitations to the specific model is that it accomplishes its goal of creating a model that can accurately predict a cancer origin. It also has a mean per class accuracy of around 91%. That's balanced across common and rare cancer types. The real-world data showed that around 60% of cancer of unknown primary patients had a subtype aligned diagnosis or medication after TO testing. It's highly interpretable, and also it has a minimal element of black box, which we'll talk about in a minute. Some of the limitations is that it's only RNA alone. It doesn't have any DNA elements that's incorporated into the model. Some of these specific types of models, such as linear models, may have some difficulty distinguishing between cancers with overlapping gene expression programs, such as pancreatic versus cholangiocarcinoma. That's kind of similar to how the IHC markers are now even struggling to separate them. Additionally, the probabilities were not formally calibrated or reported. So there's an important distinction here between accuracy and calibration. So accuracy measures how often the model is right. Calibration measures whether the confidence that is reported can be trusted. So for instance, you are given a probability that, this specific type of tumor is what it's saying it is. How confident is the model in its prediction? Calibration metrics ensure that the probabilities the model gives correspond to real world frequencies. Basically, is the confidence that they're providing you or showing you, is that accurate? And can you really use it in regards to making a clinical decision? Additionally, something that's a little bit less relevant but of note, these linear models are highly sensitive to shifts in RNA preprocessing. So you really have to standardize the input. In this case, Tempus TO does run all of their RNA internally, so that is something they are controlling for. So now let's take a look at the next model, which is the CARIS AI model. And we're going to talk a little bit about how it's different and how it accomplishes a little bit of a different goal. So first off, it is an integrated AI model embedded within routine CARIS profiling. It's designed to flag misdiagnosis and also resolve cancer of unknown primary. This is different from Tempus. The inputs are a combination of RNA expression, DNA, as well as the gender. The VAF cutoff is typically around 5% to reduce some of the noise. The output is a hierarchical probability across 90 cancer subtypes. It gives a major tumor type as well as a specific subtype. On the right, you can see an example of what we're talking about. The results are then also integrated into a physician workflow. So some of the results are going to be reviewed by a pathologist, reviewing the IHC, as well as the overall evidence, the orthogonal evidence, meaning that it's not just these three elements, but also additional evidence to ensure that the report that it's giving, the CARIS AI, actually is true, biologically true, and can be actionable. The training population is around 200,000 tumors from routine clinical submissions that were submitted to CARIS. Again, we talked about 90 hierarchical categories. No cancer of unknown primary were included in the training. It's primary as well as metastatic samples, and it's real-world data. How the cases were selected, it was really a diagnosis from submitting institution. It was mapped to OncoTree labels, and some of the tumors in the training data were given potentially incorrect diagnoses. It really depends upon the treating institution about what the actual diagnosis is. So you have to keep in mind that there might be some label noise in which the model might learn incorrect biology from the actual submitting team. I'm going to talk to you a little bit about the model architecture now. What is a neural network? It is a computer model that learns patterns by seeing many tumors with known diagnoses. It makes a prediction and measures how wrong it is. It then adjusts the internal weights to reduce future errors. It repeats this process over and over again until it recognizes complex gene patterns. And that's the trick. It's trying to recognize complex gene patterns, basically by trial and error. It learns patterns of genes working together, so not just single genes alone, like we were talking about before. This involves 20 deep neural networks, and on the right side, you can kind of see an example of what a neural network might be. You have an input and an output, and some of the intermediate steps are actually hidden, as opposed to a linear model, which we talked about before. This specific model, CARIS AI, uses 20 separate neural networks, and each act like an independent reviewer. Their predictions are combined to improve reliability. So the structure works in a hierarchy. The model predicts in steps. First, it gives you a broad cancer diagnosis, then it gives you a specific subtype. So for instance, it gives you lung, and then it'll give you lung adenocarcinoma. When you have the specific prediction, the model is actually able to penalize confident mistakes, meaning that a way of checking itself is to actually, when it was training, is that it actually is able to give itself higher marks for mistakes. If it is confident when it makes some mistakes, then that is something that is a big problem that the model recognizes. Again, nonlinear boundaries allow it to recognize complex overlapping tumor biology, something that is separate from the linear model that we talked about before. So briefly, in regards to black box, what is it? A black box model gives an accurate prediction, or it can potentially give an accurate prediction, but its internal reasoning cannot really be easily explained. Black box does not necessarily mean that it's unsafe. The risks come from overconfidence, poor calibration, and unchecked automation. In this model, individual features or contributions are not necessarily visible. And in deep models and generally are prone to overconfidence. So they can sound very certain even when the prediction is wrong. And I think that's a very important aspect to keep in mind when you're dealing with black box models, and specifically CARIS GPSai. Now, the confidence can be managed externally, meaning you can have safeguards in place. Safety comes from thresholds as well as human review, not the model knowing when it's uncertain. So the danger is that not that black boxes themselves are the problem. It's really the danger is when you use black boxes without any type of guardrails or parameters. So if you just use the model alone without the context, without the guardrails, then you're putting yourself at risk for the model to give you a very confident answer, which may be incorrect. So the key point is that it's not necessarily the black boxes themselves if the point of using them is justifiable. The danger and caution one should have is that using a black box without guardrails or parameters. CARIS manages the black box using additional workflow controls. And now let's talk a little bit about the specific scoring and thresholds, and then we'll compare each model and open it up for discussion. So the outputs have specific thresholds. The thresholds here are greater than 0.55. That gives you a reportable diagnosis, and greater than 0.90 is a diagnosis potential change is possible. So the diagnosis change is possible. The threshold is empirically chosen, and the question then becomes, are these well calibrated? How confident is the machine, and how well calibrated is that? CARIS AI, in regards to the clinical workflow and how do they actually incorporate it into their models, they use it as a critical value discrepancy, which means that if you reach a certain threshold, and if there is a conflict with the submitted diagnosis, it triggers a workflow. It really triggers a orthogonal confirmation, which means that the physician will then review the IHC, the imaging, and the mutational signatures. They're going to really look under the microscope and see if the model is, in fact, picking up an incorrect diagnosis, which was one of the goals of the actual model itself, not just differentiating cancer of unknown primary. So some of the validation and real world impact had a positive predictive value around 93 to 95%. The diagnosis changed when they did run it in real world cases, around 0.9% of cases, which I think is, arguably impactful. There's treatment implications in around 86% of those. And there was a pretty high physician acceptance rate when they actually ran this model. So this really demonstrated management impact. The survival benefit is not yet evaluated, and I don't expect it to be really incorporated or reported in the future either. It's going to be very difficult to run a clinical trial on this. Here's the most important slide for the CARIS AI, and really that it is a multimodal biology, uses DNA as well as RNA and the gender, as a very high hierarchical positive predictive value. It has explicit safety checks, and it has real world adaptation data. When they compared it to the TCGA, this is the external data set, it was around 97.9% accurate. Again, if you remember, the Tempus was around 80%. Some of the limitations was that it is a black box model, so it is prone to potential overconfidence. But when you have the guardrails intact, you can manage those. The calibration was not shown, and there is a risk for label noise. So let's talk a little bit about the direct comparison here. And I wanted to get your guys' thoughts on specifically a few of these questions. You get one of these tests and you see that your diagnosis is not matching from what they report, or if you have a cancer of unknown primary. Are you going to trust these type of models, and would that change your perception of how to treat it moving forward?
I think it's really interesting to learn how these models are designed and the two different ways of they get to the, what is the truth. I think these models are very helpful, particularly in what I do, seeing a lot of GI oncology. We get a lot of cancer of unknown primary, and there probably is a true tissue of origin that I think these kind of assays could easily assess. I think there's a separate question when you have tumors that are so poorly differentiated and there's no clear primary. What is the best step forward? And then I think that's the edges of where I think these kind of models break down probably a little bit. And I think treating as a cancer of unknown primary still makes a lot of sense to me. If the data is not predicting something with a very high confidence interval.
Yeah, I think Lewis, like when I attended the CARIS, one of their webinars, how the workflow goes, like when a case is flagged, they reach out to the treating physician and they present like why they think what they think, and some of the signatures, like they are very like specific to the cancer diagnosis. And one of the cases they presented was a dedifferentiated melanoma based on the signature, like the UV light. damage signature, which was very specific. And then when they went back and they discussed that, like it was like all over the place. They didn't know how to treat it. They was giving the patient chemotherapy. And when they stained the cancer for SOX10, which is like positive in these melanoma cases, it was positive. So many of these cases become such like back and forth. We think this is the diagnosis. What other IHC can we do? What is the pattern? And then they more like reach a consensus. I don't think it's at the stage like this is the result and deal with it. There's still more like negotiating. Patient gets more path reviews. At least with CARIS. I'm not sure about Tempus.
I think it's
So
a
I
good
think
point.
they're useful. Yeah.
I think it's a good point because I don't think you can take these models in a vacuum. You have to really consider all the clinical variables, and it might be something that evolves over time.
Right. And also the signal they get, because some of them like this is like 100% of the cancers have this signal. And what are you telling us? Like, and they look back and say, oh yes, like just like a random site of origin. There was like a breast cancer metastatic to pancreas. So the patient diagnosed with pancreas, the breast lesion wasn't seen, and the patient was treated for some differentiation. And it was again the same. Like when they look back, actually they found like the breast cancer. So I think they are useful. The CARIS GPI is different. Like it's not for cancer non-primary. You can use it for that, but was I think now the data and how it evolved was more this discrepancy, like things flag up based on very high confidence.
Yeah, I think Dr. Chandler mentioned a bit when he was working in the community practice that it was very common to get cancer of unknown primary, much more than 1 to 2% of cases that's sometimes reported in the literature.
Yeah, I think a lot of it depends on like how good. I mean, in the community, you have pathologists that are maybe not necessarily as subspecialized as you guys experience in fellowship. So they're probably good at labeling a breast cancer or colon cancer. But something that's poorly differentiated, they might, send for 1 or 2 rounds of IHCs and then basically say it's an unknown primary. So, that low-hanging fruit, I think these assays are actually really good at. From a practical standpoint, when you're seeing the patient and you're like, nobody wants to hear we don't know where the cancer is coming from. And you can get this information back in 3 to 4 weeks, then that's pretty good. And you can say with a fair amount of confidence. I think there's another issue, which is like cancers that are truly so poorly differentiated or de-differentiated, and it's hard to put them in a bucket. And I do wonder, like, you said these, Tempus is trained on like 40,000 cases and CARIS is trained on 200,000 cases. But these are standard, I would venture to say the majority of them, and I mean, that's what you were saying, that basically they're known cancer. This is a known breast cancer. This is a known lung cancer. So they fit the mold of what we were expecting. But when you get to these really, really, really differentiated cancer, do they even fit the mold of what you're testing them against? And that's a tricky question, that's where, it's nothing is 100% confidence, right? Like even these, and that's where I think the edges of these assays are probably still helpful, but, I bet you, I mean, if you practice long enough and you see enough, they are still like these very, very poorly differentiated cancers, which, wouldn't, even with these assays, won't fit cleanly in one bucket. And, I think that's also something that that's a different scenario, I guess. One is, okay, my pathologist is not great, or, like, I just need to quickly get an answer of where this is coming from. I think those are like low-hanging fruit for these kind of assays. The other more kind of a philosophical question is, or like conundrum is, what is the ground truth? If it's so differentiated, why are you even trying to put it in a bucket, kind of thing? I guess is how I look at it. And what is the benchmark are you comparing it to? So that's interesting. And it's interesting how it's approaching it from a machine learning standpoint could maybe unlock things that you could never do with IHCs, or even human pathologists could do.
Do you see, and this is open to everybody in the panel, do you see a problem or do you have concerns in regards to using some of the more black box models that may be prone to being overconfident in giving a diagnosis? Or do you think that you just have to take it in context and use the guardrails in place?
Just, I think I'm gonna comment. In both models, like they try to minimize noise and use relatively high threshold for association between genes and cancers, and they are very cautious. I think both companies are worried about that, and they themselves like trying to have some protection to the public from these tests. Yeah, I don't know. But you see, like the enrichment cutoff was 10 to the power of -16 p-value to be significant.
So none of these currently are incorporated in the NCCN. Do you think that they should be?
The CUP, they haven't. I don't think they have updated the cancer from an origin for a long while. Maybe with the next update, they might be included. And then just to that point, like if someone seeing a large volume of patients, and some data they say like cancer from an origin is up to 5%. That's 1 in 20. So if you see 20 patients a day, one of them theoretically could be a CUP. That's a lot. Like,
Do you think you would send the test?
I would.
You would.
Yeah, I think it's more like for immunotherapy. Something like this may be lung. Like, yeah, I'm gonna fight for immunotherapy.
I think that it could also give some evidence to support, insurance claims and in regards to a treatment that you may want to give that might not be indicated for just cancer of unknown primary.
Exactly, because you got these like melanoma, it could be like renal primary, and then what am I doing? Like giving chemotherapy, maybe just gives you more of a reason to give immune or like a VEGF inhibitor or TKIs. Yeah, I think it has a role, especially these patients, they don't do hot anyway. Like, so if you have something that may help them, like prognosis is less than a year with treatment.
So these are the early models. These are both the beginning. These are the first attempts by both of these companies. I suspect that in the future, they're going to continue to evolve and give new generations for these models. And I expect that they're going to release a bunch of new data in the next couple of years. Specifically, Tempus, I suspect, will release an updated version that involves deep learning rather than just a linear model. How would you even incorporate this into a potential prospective trial? Would you just run it based on cancer of unknown primary and see if adding this model actually changes the prognosis? It's hard to say. How would you do a prospective validation of some of these tools?
I don't think it's going to be like in the trial, but it's going to be just more of a retrospective after they get so many of these patients and see like how would they categorize and see like what was the outcome of the intervention. But having a trial for this, yeah, it's really hard to pull, like to enroll and
exactly
diverse
very diverse.
Diverse population with diverse treatment. And then what's your control? Like if you think it's helping, like who's going to be agreeing to the like shooting in the dark arm?
I do think it is probably, I think ironically, one of the best things to consider with these tools is that we're so certain when we have the diagnosis that if we do send these CARIS tests and we get flagged and it does report that it's a different primary than what we think, I think that has probably a very high clinical relevance and a high clinical impact, even if you're, changing the diagnosis of 1% of the population. If you scale it to all the cancer patients that submitted to CARIS, that's a huge population. So when you have discordant results from the blood and then the actual tissue itself, it kind of puts into an interesting situation. But you said it was 90% confident from the Guardant reported?
99, yeah.
99. That's interesting. We didn't review the Garden specific test, which is a blood test, but I could not find very good data or publications to explain exactly how they're getting their actual results.
Yeah, it would be nice for them to.
Yeah, that seems kind of, that's a suspect to say you have a blood test that you're saying 99% confidence interval when tissue-based testing is like, giving you 80 to 90% confidence intervals.
Right.
I don't know. I just find that kind of a little bit suspect, right? Because you can have a KRAS mutation. I wonder if, like, you pick up a KRAS mutation, but that could be from an IPMN or even a polyp. Like, it's something along the pancreatic cancer spectrum, but is it invasive, pancreatic adenocarcinoma?
Yeah. Well, so the CARIS, the GPA is pending, but CARIS and Garden have both same profile, genetic mutation profile, and one of them was like SMAD4, which is pretty specific for pancreas, I heard, and then also like KRAS, STK11 plus TP53. I was like, okay, this is 3 against 1, so maybe lung can be fitting into this, but again, it turned out to be more like, I guess SMAD4 was more specific for pancreas on top of KRAS, I think.
Yeah, so like working through these cases is like very, very tricky, right? So like,
yeah,
like if you have a Garden test that tells you with 90, quote unquote 98% confidence interval, this is a pancreatic primary, and what tissue did you send to CARIS? A lung biopsy?
yeah.
I wonder what if that comes back with 98% confidence or whatever, 90% confidence is a lung primary, then, that just throws somebody under the bus. You just gotta wonder who's who.
True.
And that's what,
or you have two primaries.
Yeah, you're two primary. Yeah, that's
two primary. Yeah.
That is another limitation also here that it's very possible to have 2 different cancers. Specifically, let's say you have prostate, you could have neuroendocrine elements within the prostate. Okay, well, that's all I have. Do you guys have any other questions in regards to these models, or any other specific questions in regards to how they made it or validated, or how the actual evidence is supporting it?
No, but I think it's an interesting concept. So thanks for giving the presentation.
Yes, thank you.
Thank you all for coming. Appreciate it.